All right, so hello everyone. For those who don't know me, my name is Maria Zulfiqar and I work at the Mayo Clinic in abdominal imaging. So I'll be talking about oncological pitfalls and mimics in the pelvis. No disclosures. All right, so when I was like preparing this talk, so I kind of started thinking there was the difference between a pitfall and a mimic. And a pitfall is like when a malignancy is missed. And we're like just talking in terms of oncology. There can be like pitfalls and mimics with respect to other stuff too. But oncologically, when a malignancy is missed, it's either not picked up because of a finding or could be passed on as a benign finding on imaging, then that's a pitfall. And then a mimic is when a malignancy is overcalled, when a benign diagnosis kind of masquerades the cancer. So it's a case-rich presentation. Here I'm showing you a case of a young, relatively younger person, 40-year-old, presenting with rectal bleeding. And right off the bat, there on the MRI, it's very impressive. The eyes like straight away go to this finding where you can see that the rectosigmoid colon is like very thickened. It's like T2 hyperintense signal there. It's more or less is like shine through, but in the middle of all this is like, there's a slightly different finding, which you can see is mucosal base. It has different signal compared to the background rectum, and also has diffusion restriction. So something is different than the more abnormal or eye-catching finding. And on CT, you can easily correlate that this thickening, which is T2 hyperintense, has a lot of phlebolytics and is compatible with the rectal hemangioma. But it's very good that you can diagnose the rectal hemangioma, but it's important to kind of find that cancer that's like sitting in the middle of it and trying to hide in plain sight. This is what we call is like a satisfaction of search pitfall, where you can see that a more eye-catching finding kind of sways the eye away from a more clinically sinister finding, I would say, which this was actually picked up on colonoscopy and missed on MR. And this was consistent with the tubular villus adenoma with high-grade dysplasia. So try not to get, too excited about like a relatively benign finding and keep looking for additional findings, especially in a patient presenting with rectal bleeding. So a lot of like everybody is human, radiologists are human, and it's not uncommon to miss stuff just because a finding is just like simply missed, which is the underreading error. But here I'm showing you a classic example of satisfaction of search, where more flagrant finding kind of hides or masks the cancer. This is a case I'm showing you of a young patient presenting with bilateral ovarian masses. And you can see that the right ovary is enlarged and has like a cystic as well as solid areas. And you can see that there's this classic sea anemone sign. And this is compatible with a borderline ovarian tumor. But what's important is not to miss the contralateral finding in the ovary. It's subtle, but you can see that there are like some papillary projections within the left ovary. And 30% of these tumors are bilateral. So when you see a tumor in one ovary, kind of, although the left ovary is normal in size, you can kind of see these like papillary projections. So kind of slow down and kind of zoom in the left ovary or the contralateral ovary if you see a mass in one ovary. Same thing with prostate cancers. You can see that there's this Peyer's 4 or 5 lesion in the right prostate, but these prostate cancers can have concurrent or concomitant or synchronous, I think that's a better word, urinary bladder cancers. And because we do these like small field of view prostate MRIs, it's these cancers can be just hiding at like the first slice of the the stack of the images. So make sure that we look at the bladder in these prostate cancer patients. This was urothelial cancer in a synchronous urothelial cancer in a patient with biopsy-proven prostate cancer.
Maria, can we ask you questions along the way?
Yeah, sure.
Okay,
Yeah.
going back to that one, we said 70% of prostate cancers in patients with bladder cancer.
Yeah.
That seems really high to me. And so my question is that just because prostate cancer is so common, or because the bladder cancer, like the urothelial cancer, is spreading to the prostatic urethra kind of thing?
It could be because of that. I didn't really look into details of this paper, but
Okay, no.
yeah, they were maybe it's the population they have is showing that high rate, but just make sure that both of these tumors can happen synchronously. So just make sure that we have if you don't focus your eyes on the prostate alone on these prostate MRIs. I'll make sure that you look for look at the bladder too.
Yes,
So
and also
yeah.
rectal. Nellie presented
Oh yeah,
for incidental
exactly.
rectal cancer. Yeah.
I always look at the rectum to look for a cancer. I've seen other people diagnose it, but I still have to have my very own case. Well, I always look for one, but I'm hoping that I'll have one, but we'll see. Yeah, rectal, but yeah, there's a high association basically between bladder and prostates, so urological malignancies. So these two, and obviously the rectum, I agree with you. All right, this is a 30-year-old woman with recent miscarriage, and she's presenting in the ED with diffuse abdominal pain. And of course, CT is faster modality to obtain for, especially in a postpartum patient or post-miscarriage patient with abdominal pain. And you can see that the uterus is enlarged, it's very heterogeneous, has a lot of hyper enhancement. You can kind of see that there's soft tissue, which is hyper enhancing, extending outside the confines of the uterus. And then she has a hemoperitoneum in the right pelvis. And you're preparing your mind, okay, this is probably a choriocarcinoma. And, in a setting of recent miscarriage, and you're okay, let's check the beta HCG levels. When you check the beta HCG levels, they're negative. And you're oh my God, this does not add up. The imaging and the labs don't add up. So this is a case that I had as a fellow, and I did not know about this phenomenon, but the point of care beta HCG that are usually faster to get, but they are qualitative. So they have this pitfall where if you have a cancer which is very aggressive and produces that antigen or antibodies that are used in these immunological reactions, when it is produced in such a high quantity that it just saturates the receptors on the detection antigen or antibodies that these immunological tests use. So that gives you a false negative point of care HCG test for these choriocarcinomas. The better test is the quantitative test, which you can see this is her initial test before the DNC, before she got resected. And as she got chemotherapy, it kind of came down. But yeah, the point is that the quantitative is better than qualitative, especially if there's an aggressive tumor that's producing a lot of beta HCG. And this was path-proven choriocarcinoma. All right, this is another 31-year-old man presenting with fever and urinary burning. Sometimes the clinical picture that the patient is presenting with can be very misleading to the radiologist. So he's presenting with fever, urinary burning, and history of prostatitis. He's being treated with antibiotics, and this is the CT in the ED that was obtained. And you can see that there's this very thick wall collection between the bladder, over the prostate, also abutting the rectum, has these sinus tracts extending into the adjacent fat. And it looks very kind of infiltrative. And when you're looking at his white, he also has a white count. So you can't help but think that this is an abscess, kind of like a complication of prostatitis. So of course, this patient was, a drain was placed, and they also got a little bit of pus. And then 3 months later, he presents with this. And there's a drain in place, and you can see that this collection has not only gotten bigger, it also has more mass effect. There's frank fistulization with the urinary bladder, and there was little to no drain output. So all of these findings, and they were it points towards something like much more um, uh, like oncological rather than just a simple abscess. So when you have like a patient, especially like patients with like chronic inflammation, like Crohn's disease or a chronic abscess cavity, who are presenting with these collections which are worsening and drains, they actually upsize the drain on this patient and still no output. So why is it not draining? Because this is all like mucinous collections, and this happened. And then they obtained an MRI, and you can see that there's this rectal tumor which is like perforated and has like mucinous collections in the pelvis, and it's fistulized to the urinary bladder. It also has like this mucinous lymph node along the inferior mesenteric chain. And then on post-contrast imaging, which I feel like on MR you can see this enhancement a little bit better than CT, is this like kind of nodular, irregular, marginal enhancement of these mucinous tumors. Sometimes they can have like an internal web-like or lacy pattern of enhancement. But yeah, especially be careful in the setting of like Crohn's disease, um, or like a fistulous cavity getting like bigger and bigger because it's like complicated by a mucinous tumor now. Some clues that you can have on imaging, like I said, if you see like lymphadenopathy, if you see this like peripheral nodular lace-like enhancement. But when these tumors, like in this patient, I think initially he was superimposed with infection, it's harder to differentiate initially. But like with the evolution of findings, I think if you see fluid collections getting bigger, have a low threshold for like asking for tissue sampling, especially along the margins. I think they should target the margins to get like more yield for tissue sampling. Usually PET CT is not very helpful in differentiating abscess versus like a mucinous tumor, because predominantly the FDG activity is like peripheral, so it's harder, and it's just like, could be tumor, could be could be inflammation. So I think I tend to recommend tissue sampling a little bit like more forcefully if I suspect that something like this is happening.
Maria, I've seen several of these cases, and it is always sort of like multiple scans where you think it's just an abscess, but it's growing. But definitely, I want to emphasize your point about MR can be much more helpful than CT, because CT it just looks like a fluid collection, and then MR you start seeing all the structure inside of it. So I would say also have a low threshold to recommend an MR.
Oh yeah, for sure. Yes. All right. So now coming to the part about mimics about malignancy, which are much more than it was really hard finding like pitfall cases of malignancies where malignancies were missed. I think in general, abdominal radiologists are like really astute in picking up these findings. But there are certain like benign conditions that can mimic malignancy too. And malignancy can be overcalled and sometimes can lead to like unnecessary intervention and tissue sampling. So as one of my mentors told me, like the female pelvis is like a hotbed of pathology. So be always be on guard about like, stuff trying to trick you. And then in the male, relatively less real estate, but like prostate can be a little tricky. So I've for myself, I've divided these like mimics into like tumor-like conditions, infections, and then iatrogenic, of course. So starting off, I'm showing you a case of a young man who has history of seminomas in the testes, and then he's gotten a CT for like staging of the disease. And at that time, his NF1 status was not known, but you can see that there are these like low attenuation masses in the retroperitoneum, and they can easily be mistaken as metastatic lymphadenopathy. But certain clues that can help you in diagnosing this case is that it's really typical for these masses to kind of have this like elongated tubular appearance, and they follow along the course of the nerve roots. And they also tend to like nicely modify the neural foramen, as you can see in the sacrum. And then he also has these like subcutaneous nodules in the skin, which are neurofibromas. So putting everything together, these are consistent with like neurofibromas rather than like metastatic lymphadenopathy. So kind of like keep in mind about like these can trick you into calling metastatic lymphadenopathy and can lead to an unnecessary biopsy. And then also there's like this weak association between NF1 patients and even though these patients are already they are high risk for developing different types of cancers, but seminomas, one of the gene mutation is associated with NF1 mutation that causes seminomas. So there are like some scattered case reports available. So kind of be on guard, not to overcall these neurofibromas as Mets.
Wait,
This is a
sorry, I spaced out for a second. Those things in this particular patient and those testicular masses were
seminoma.
seminomas?
Yeah.
Oh, and can you also, but like probably you can also get neurofibroma. So basically they just have to
this is
biopsy or resect them.
This is an archaeectomy proven case. So he initially presented with a testicular mass, and like as they do, because he's a young person, and because of the, it was called as a seminoma on ultrasound. It has like very heterogeneous appearance, internal vascularity, and not showing very well, but it also has like internal like echogenic foci as well, so kind of microcalcifications. So this was called as a seminoma, and this patient had an orchiectomy, and then they did like a follow-up CT for metastatic disease.
Got it.
Yeah. All right, this is a young woman. She's 20 years old, and she's presenting with urinary tract symptoms. And CT was obtained, and you can see that there's like this diffuse mass-like enlargement of the urinary bladder. And there's also like mass-like enlargement of her cervix, and there's this mass-like infiltration into her like perineum and her vulvar region, and also like the mons. And you can like when it was read as a CT, also her NF1 status was not known. So it was a lot of like differential diagnosis was thrown around, including like a rhabdomyosarcoma, of course, a neurogenic tumor, like some weird form of fibrosis. I think if I remember correctly, there was this like foreign body reaction differential diagnosis. So basically nobody exactly knew what was going on. And then she got a follow-up PET MRI too at some point, and you can see that there's like this, all of this has like very low level uptake. And like one radiologist, he was an MSK radiologist, he picked up this like scalloping of dural ectasia along the posterior margins of the vertebral column. And he suggested that this is all like a plexiform neurofibroma. And when they biopsied it, it was like, it showed like neurofibroma. So just like little clues on imaging can help you kind of narrow down the diagnosis. So always look for like, when you have like a really atypical appearance of something, always look for like clues on imaging to kind of help you pick up and narrow down the differential. And this patient was followed over like several years, and everything has remained stable over time. All right, jumping into endometriosis, which is like a great mimicker in the female pelvis. I put it under tumor-like conditions because at times it can look like a tumor because it has like various morphologies that you can see on imaging. On imaging, like if you look at on CT, like most of us are kind of used to looking at endometriosis on ultrasound, where you see these like low-level internal echoes, posterior through transmission, kind of like thin wall. That's like a no-brainer on ultrasound. But on CT, these can look like kind of cystic collections or lesions. So try not to get like, especially if if the patient presents with abdominal pain and the ED decides to get like a CT. So these can kind of mimic cystic masses in the ovaries. But MRI, it can also be helpful. They have like classic T1 hyperintensity with T2 shading sign. But like this is like much more like an endometrioma case that I'm showing. But certain forms of deep infiltrative endometriosis can be really tricky and can appear like really mass-like and enhance like a mass. So for example, in this patient, I'm showing a patient has a history of prior C-section, And you can see that along the left anterior abdominal wall, there's a soft tissue mass, which on MRI has like T2, T1 and T2 dark signal and has enhancement on post-contrast imaging. And on ultrasound, it looks really scary with like dark, irregular shadowing. But in a reproductive age woman with a history of C-section, I think this diagnosis should be on your radar. And this was actually ablated for management purposes. And before they biopsied it, of course, and this is path-proven endometriosis. Let me go back, I think. Okay. And then there's this like another entity that can happen with deep infiltrative endometriosis where colon remote to the side of the pelvis can get involved. This is called as the fortune cookie sign. It is kind of like the sister sign for the mushroom cap sign, which happens with rectum, rectosigmoid. But this fortune cookie sign where the serosal implant kind of involves, it can involve the descending colon away from the pelvis, or it can involve small bowel loops in near the pelvis. The idea is that the endometriosis deposit, it starts infiltrating from the serosal surface and forms this submucosal mass, and that kind of puckers the serosa and gives it like this fortune cookie appearance. They can be single or multiple, and I've seen it being misdiagnosed as like possible metastasis or lymphoma because they are multiple and the history of endometriosis is not known. So just keep in mind this classic appearance. This is consistent with deep infiltrative endometriosis.
Maria, question.
Mhm.
That almost looks kind of like the tubulovillous adenoma you showed earlier.
Yeah. Yeah, but it doesn't really kind of puckers the appearance like that. So it's usually T2 intermediate in signal. It can enhance, but the tubulovillous adenoma had a relatively darker T2 signal.
Yeah,
So
like more of a core to it.
yeah, but the way that it kind of puckers, this kind of forms this kind of like this fanned out appearance. That's very classic for endometriosis, the way it kind of starts and it's based on the mechanism that it starts infiltrating from the serosal surface and kind of grows into the submucosa. So that kind of gives it this classic appearance. And the mushroom cap sign also has the same basis. And also the demographics of the patient will help you narrow down this diagnosis. Um, Polypoid endometriosis is a rare, it's a morphologically and histologically distinct subtype of endometriosis, and it can look very mass-like. It's T2 hyperintense. It can look very cystic, but it can also look almost like, like a mass on MR. And you can see that there are like some scattered foci of T1 hyperintensity in it, but it may not always show this like entirety of T1 hyperintensity. And you can see that I'm showing a subtraction image to show that it's like enhancing very like a big mass. And that can be challenging for diagnosis when you're diagnosing and difficult to differentiate from endometrioid cancer, which, everybody kind of looks for that, especially in a kind of like an older age woman with the long-standing endometriosis. But I feel like at times, like I've read some papers and they say that the degree of diffusion restriction can help. Normally there is a level of low level diffusion restriction in endometriomas and polypoid endometriosis, but they're not intensely restricting. I'm showing an ADC to kind of show my point that there's not much very intense diffusion restriction. And this was path proven, and you can kind of see these like polypoid growths over this like enlarged ovary on gross anatomy. So kind of, sometimes, of course, it's not going to be possible to 100% differentiate, but you can always suggest this diagnosis, especially when there's like T2 hyperintensity and then not much diffusion restriction. If there's intense diffusion restriction, I would worry about malignancy. All right, jumping on to infection. Well, all of us kind of know that, pelvic inflammatory disease at times is associated with tubo-ovarian abscesses, and those can sometimes be very large and enlarge the fallopian tubes so that, because of the space limitation in the pelvis, it just kind of like loops upon itself. And when you're looking at on like cross-sectional imaging, it almost looks like a septated, multiloculated cystic mass. Few things that kind of help you if you try to follow these tubes, you can kind of follow them like a tube. Especially coronals are helpful, sagittals are helpful in assessing, and pelvic fat stranding, which is associated with inflammation, is helpful for differentiating a tube ovarian abscess from a possible cystic neoplasm. And then, of course, the clinical presentation of the patient. These patients will have white count, will have fever, and on imaging, you will see this, what we call as a cog wheel appearance, where you can just follow these tubes. And if, all fails, then of course, MRI is always there to kind of troubleshoot. Atypical infections such as actinomycosis can be very tricky. It happens classically in the presence of a long-standing IUD, which is present for more than 3 years. And you can see that in this patient, there's this long-standing IUD and all this like mass-like thickening and enhancement, and it's like very fibrotic, and it's like not respecting any boundaries, just going through the anterior abdominal wall, involving like forming sinus tracts and causing all this kind of mass-like thickening in the anterior abdominal wall, and can very well be called as, a malignancy. But if you kind of put into perspective the presence of long-standing IUD, then you can always suggest that there's this like probably an atypical infection happening, and they can kind of do tissue sampling and test for that organism, actinomycosis, which is a gram-positive non-acid-fast anaerobic bacteria, and narrow down the diagnosis for these patients. And this can look like really complex on imaging because it forms like the inflammation forms like this firm fibrotic tissue and necessitates tissue sampling. All right, ovarian hyperstimulation syndrome, if it's like simple, it's easy to diagnose on imaging, but because of the strong hormonal stimulation in these patients, these ovarian follicles, they grow large and the ovaries are like really huge. And they have these follicles arranged in a kind of like a nice spoke wheel pattern. And these patients can also have ascites because of volume overload. But I'm showing a case here with ovarian hyperstimulation where these follicles hemorrhage. There's also hemoperitoneum. So in those situations, it can be hard to differentiate from malignancy. But of course, you will kind of knowing the IVF stimulation history is very important in these patients, and will help you kind of, suggest that this is probably hyperstimulation that has ruptured and causing hemoperitoneum rather than an underlying mass. These patients, of course, will, like for this CT patient was followed for a good 1 year after this, until everything kind of like, settled down and it was proven that there was like no mass in the ovaries. But knowing this classic appearance can kind of help you, especially for like younger residents and trainees. They can get really excited about calling it a cystic, multiloculated cystic mass, especially on CT. So history is basically the key, knowing that this patient has had IVF hormonal stimulation. This is a patient presenting undergoing prostate cancer screening for elevated PSA levels. And you can see that there's a Peyer's 4 lesion, T2 hypointense, nice focal marked diffusion restriction. This was called as a Peyer's 4 lesion. And when it was biopsied, it came back as non-necrotizing and necrotizing granulomatous inflammation. This patient had a history of urothelial cancer, and he had BCG therapy 6 months ago. So knowing the history can help you, suggest that this could be a granulomatous prostatitis case rather than cancer. And then 2 types of patterns have been identified for this granulomatous prostatitis. There's a chronic pattern when usually happens when the therapy was BCG therapy happened more than 6 months ago. And then there's an acute pattern which mimics a Peyer's 4 or 5 lesion, and usually is like larger than 1.5 centimeter. Like I'm showing you this case, this is like a whole diffuse granulomatous prostatitis in this patient with the BCG therapy. And then the chronic pattern mimics more like a Pyrus 3 lesion. So knowing the history when the BCG therapy happened can help you, you know, kind of put this diagnosis. Okay, this is like my favorite category, the iatrogenic, which I also have been embarrassed by several times when, you know, the clinician calls you, hey, I did this intervention. Could this look like that on imaging that you're calling, you know? And I'm like, okay, oops, sorry. So here's the case, patient with urothelial cancer, and he's being followed up for metastatic disease. And I saw this is a contrast enhanced study, and this was new from the prior study. And I was like, oh my God, these are like all metastatic recurrent nodules in the bladder. And I called it like disease progression. And then the urologist called me and I was like, I injected trace IT hydrogel, and can it look like that on imaging? And I was like, oh yeah, it is hyper dense, but we can get a non-con to kind of confirm. And then we got a non-contrast CT, and you can see that all of these nodules are hyperdense and they're not truly enhancing. So this trace IT hydrogel, the urologists are using more and more now to kind of for precision targeting for radiotherapy. And just make sure that you don't fall into that, you know, uh, mimic pitfall that, you know, and call it like recurrent tumor. And there is temporary and usually gets absorbed in about like 3 months, but can really look like nodules and masses on imaging. So kind of beware. Another urological pitfall when they inject this bulking agent to prevent reflux. There's this like low attenuation, kind of very well circumscribed nodule appearance of this bulking agent injection, which they did to prevent reflux. And it can look very tricky because it can look like an obstructing lesion, because as you can see that in this patient, there's this asymmetric right hydroureter nephrosis, and you can kind of attribute that hydroureter nephrosis to that space occupying lesion, which is actually the bulking agent. And knowing the history and comparisons, if you have comparisons comparing with priors, can be helpful in not calling this a cancer. In my defense, I did not have any priors, so so that's why I think I fell into that trap a little bit faster. But you know, reading the urologist note if it's available, and knowing the history, and also like very nicely circumscribed and low attenuation appearance. Cancers kind of don't have that low attenuation appearance, so you can suggest this diagnosis on imaging. This is a case I'm showing of a right inguinal nodule in a patient with a history of lymphoma. And you can see that there's this like soft tissue attenuation in the right inguinal area. And it has like slightly T2 dark appearance, but it has enhancement to it. And it has uptake on PET CT. So, but this is a classic location, and also like this conical kind of oval appearance, and location is classic for a mesh plug. And the important thing to know is that these mesh plugs can have, they basically are designed to incite a granulomatous response and induce fibrosis, so that, you know, there's less failure and more fibrosis and less chances of recurrence of the hernia. And they, because of the granulomatous reaction, they can have uptake on PET. So not to kind of make sure that you don't, even in this patient with lymphoma, and knowing the history, when you look at this, the site, checking the patient's chart, I always do, if he has history of a mesh plug repair, and that's what that is. Sometimes you can kind of see these undulations of this like kind of puckered appearance of that mesh on on the T2 weighted imaging, but in this case, it kind of looks like a nodule. Thankfully, this was not biopsied. It was like rightly suggested on imaging that this is a mesh plug with some granulomatous reaction, giving this appearance on imaging. But knowing the history can help you avoid this mimic being called as a malignancy or a lymph node, enlarged lymph node in a patient with lymphoma. This is like by far my most favorite case of this whole talk. So I'm showing it in the last. So this patient had unexplained hypercalcemia. And the doctor, ordering physician, was worried about cancer, and they got this PET CT because they were looking for malignancy, and all of this like subcutaneous gluteal soft tissue that looks for some not very nodular and mass-like lit up on PET and has all this like FDG activity. And this is like, the location of it, the appearance of it is very classic for aesthetic injections in the free silicone injections in the gluteal region. But the problem that can be encountered is that, first of all, free silicone injections are not legal in the US, so patients may not be forthcoming about this history. And second of all, which I didn't know before this case, was that these silicone injections can incite a very intense granulomatous response, and it can be very avid on PET, and then it can also incite hypercalcemia that can mimic a paraneoplastic syndrome. And you can see that this patient's calcium is elevated, and the treatment is steroids, basically to kind of control that inflammation and control that hypercalcemia. So, and then I have had multiple clinicians basically asking for like biopsy for this condition, but this is a much more typical appearance where you see areas of calcification, areas of fat necrosis. But even if you like, see it without, always check if the patient has had like free silicone injections, because of the location is just so classic and it's just so symmetric, and can easily be mistaken as malignancy, especially when it presents like with hypercalcemia. So that's about it. But the overall takeaway point of this talk is that malignant tumors can be missed, or sometimes can be mistaken as benign, and certain benign conditions can be mistaken as malignancy. Deep infiltrative endometriosis has many faces, so be very careful, and can be mistaken for malignancy. And always correlate findings with patients' demographics, clinical history, and lab correlation, to kind of, sometimes the radiologist is the only person who is like putting everything 2 + 2 together and can drive the correct management for these patients. So yeah, that's it. Thank you, everyone.
Maria, amazing.
Oh, thank you so much.
That was awesome.
Thank you.
The chat is blowing up.
Yeah. I hope like people, learn from it. And I've made mistakes. This is like a lecture paying homage to my mistakes. So so that, people can.
Yeah, I know, but I
can be
think you
careful.
really nicely covered a lot of really classic ones, but then also like
Yeah.
added all these great clinical tidbits, like that it can actually give you hypercalcemia if you have a granulomatous reaction.
I know. I didn't know about that before that case. So the nephrologist called me, and she was like, "Oh, I need biopsy," and and I was like,
Yeah.
okay, the location kind of looks like aesthetic injections, but I wasn't really sure that how the hypercalcemia fit into all of that. So, but then I read up on it, and of course, it can cause hypercalcemia. It can mimic a paraneoplastic syndrome. So,
And I have seen mesh plugs biopsied because they were FDG avid and called
I've
pathologic
seen,
lymph nodes.
I've seen, especially when this initially came, and then we were not really used to looking at them on imaging, especially when they were like avid on PET CT. It's like, oh my God, and then just put a needle in it.
And then I found some case like literature about it, and I brought it back to my nuclear medicine colleagues, and I was like, stop calling these, lymph nodes. Cool. Okay, I think Anu has some cases.
Yes, I'm going to try and you can.
Yes, go.
Okay, so the history is, this is a young woman who was trying to get pregnant. And so she noted that her home beta HCG, urine beta HCG was positive. So, and then she had some bleeding or spotting. And so she came into the hospital, and rightly so, she got an ultrasound, and these are the ultrasound findings. So this was labeled as transverse uterus. Here are the sagittal images. These are the transvag labeled as sagittal uterus. And there is, I want to show you the Doppler image as well. So any thoughts so far? I'm going to try and bring up the...
Rupa saying molar pregnancy.
Okay, that's a good thought. And exactly, yes. So, you know, given this cystic appearance, the uterus looks enlarged. Give me 1 minute. I want to show you the Doppler image as well. So that's correct, Rupa. That was the thought process, that this might be a molar pregnancy. And so the patient was, yeah, this is the Doppler image here. So they were scheduled for BNC. And so they were brought to the OR. And I'm going to show you the intra-op images in the OR. So as you can see, there is air here. And what they realized intra-op is that this structure that was thought to be molar pregnancy is not really communicating with the endometrial cavity at all. And the air that you see actually represents the endometrial cavity. And so it was rightly concluded that this is an extrauterine lesion. And so then they, yeah, you can see air bubbles within the endometrial cavity. So there was no intrauterine pregnancy. All this was outside. And after this, so in the meantime, this is an older case, so I don't know about exactly about the beta HCG levels, you know, whether they were commensurate with the molar pregnancy. But I want to show you the CT that was subsequently obtained in this patient. So these are the axial images. You see this mixed attenuation lesion that is outside of the uterus. And then I'll show you the SAG here. So as you can see, this is the uterus right here. This lesion is outside. This was subsequently removed surgically, and this turned out to be a fibroid with hydropic degeneration. So, you know, I've never seen fibroids with hydropic degeneration. I've seen them with red degeneration, but I don't know if any of you have come across a fibroid with hydropic degeneration. So I was reading about it, and what this entity is basically, it occurs rarely, as you can imagine. It can be more commonly associated with pregnancy, and fibroids that undergo hydropic degeneration tend to double rapidly in size, and so they mimic leiomyosarcoma or a uterine malignancy that can increase rapidly in size. But the unique feature about these is they accumulate fluid within them, and there is some sort of hyaline degeneration. And you know, under microscopy, apparently there is this split fiber sign where fluid kind of insinuates between the smooth muscle fibers of the fibroid. And on MR, they can look very cystic, very T2 bright. I haven't seen an MR appearance of hydropic degeneration of a fibroid yet, but they can mimic, like in this case, as Rupa rightly pointed out, they can look like molar pregnancy. The one thing that was rightly pointed out by one of my colleagues here, who is like a GYN specialist, is the reason I showed you that Doppler image is because hydatid moles or molar pregnancy tends to be very vascular, whereas this one on that image that I showed you on the Doppler image had very little vascularity within it. I keep losing that Doppler image, sorry. But anyway, that's one of the features that can help distinguish a molar pregnancy, which tends to be hypervascular, from other entities that can mimic a molar pregnancy.
I want to give a shout out to the other Anu from Northwestern, because she got it in the chat.
Oh, awesome.
The degenerated
Indeed.
subserosal fibroid.
Excellent. Very nice. Now I want to share next case. Older person comes in with a short duration history of abdominal pain. Gets an ultrasound first, and these are the cine images of the ultrasound abdomen. So the tech, kudos to the tech, astutely notices some mass-like abnormality in the surrounding the liver, and they hone in on that area, as you can see here. I'm going to go through all these clips. At some point, the liver surface looks nodular, and they do put color on it. All other organs are fine. And this is the key abnormality that they focus in. So I was reading this ultrasound, and I was worried about this finding. And so we got a CT next. And these are the CT findings. So taking you through the axials, there is a focal lesion in the liver. And then the abnormality we saw on ultrasound seems to be encasing the liver itself. It's all on the surface of the liver. And so when we looked at, it enters the falciform ligament here, encases the left hepatic lobe. When we looked at it, we were rightly worried about some sort of peritoneal carcinomatosis, but we could not figure out the site of origin of this mass. One thought was, is this gastric in origin, but all of it is exophytic and associated with peritoneal carcinomatosis. So that was one thought, and I'm going to show you the PET CT before I tell you what this turned out to be. So as you can see, all the soft tissue around the liver is extremely FDG avid. And then they biopsied this mass, and this turned out to be a primary leiomyosarcoma of the peritoneum. We've seen peritoneal mesotheliomas, liposarcomas, but leiomyosarcomas are uncommon primary neoplasms of the peritoneal arising from the peritoneum. Unfortunately, they weren't long enough to get treated, but I have not seen as many leiomyosarcomas arising from the peritoneal cavity, and I thought it was.
Yeah, it's so infiltrative. It looks so different from normal leiomyosarcomas.
Yeah, very diffusely infiltrated.
Rupa was thinking about a primary capsular malignancy, and I was thinking TB or fasciola. So I was going to ask you if they had recently eaten watercress in Southeast Asia.
Yeah, no, all good thoughts. I guess in such cases, providing a differential and then going straight for the biopsy, because this is so superficial, I guess is the way to go. So that's
very cool. Okay, I want your input. This was a young woman who had all of these multiple pulmonary nodules for years. So she was diagnosed with these pulmonary nodules. They were thought to be too small. They were followed up. They weren't growing for a very long time. Does anyone have any thoughts on what these pulmonary nodules in a young female could be?
Some kind of vascular malformation, Aarti.
Vascular malformation? Like what do you mean?
Like HHT type.
Oh, interesting. So HHT, or formerly Osler-Weber-Rendu, these look really like nodules, not like AVMs.
Since you're showing like we are abdominal radiologists and like chest finding, I'm going for the zebra, like a metastatic leiomyomatosis.
Okay, good thought. Which you can get in your chest. So it is actually something that you can usually get in your lungs, liver, and bones. I did not know you could get it in your lung, but this patient was followed up for many years, and then, oops, sorry. Let me just stop sharing for a sec. Okay, so they've been followed up for many years, and then eventually something different happened where they started developing this huge pleural effusion. They still have all of those lung nodules. Some of them were getting bigger. There were more of them popping up. And on this chest CT, they also started noticing, I think it was here. No, maybe it was somewhere else. Hold on one sec. Okay, it was this one. They started noticing that there were some lesions popping up in the liver. that they had not seen previously. So we have new liver lesions and all of these lung nodules. And the lung nodules were growing in number and size. They ended up doing a wedge resection, and this came back epithelioid hemangioendothelioma. So I know we've shown cases of that in the liver, and as abdominal radiologists, we all know that, that they can be multifocal subcapsular targetoid lesions in young females in the liver. What I learned was that also lung is actually even more common, and lung has a worse prognosis. So the main places you get EHE, which is a vascular tumor, is the lung, the liver, and the bones. Lung has a slightly worse prognosis, although it can be indolent for a long time and then can start progressing. So same thing with the liver, it can be indolent. Sometimes some of those patients we just follow up. And if they start progressing, that's when we start thinking about chemotherapy. So just wanted to show this interesting case of a biopsy-proven EHE that started in the lungs and eventually progressed in the liver. Any comments?
Good one, Aarti. Have not seen them as such tiny nodules.
It was not on my radar. So, and we thought like, oh, did it spread from the liver to the lungs? And we found out that like, you can actually just have it in lungs, and it's kind of this multifocal systemic disease. I'm going to stop sharing for one sec. Okay, another quick one. I want some audience participation. This patient presented with left flank pain. This was a non-con CT that was done. Any thoughts?
Left kidney looks big.
Yeah, the left renal vein looks enlarged. There could be a thrombus there.
Yes, excellent.
Yeah.
So this was concerning for a venous thrombus that was causing engorgement of that kidney. Just move this for one sec so I can pull up the next one. Okay. That was an outside scan, so I'm not exactly sure what happened, but then this was the follow-up scan a month later.
Contralateral side looks abnormal.
Yeah. So it's really strange because we do see thrombus in that left renal vein, but now we also see a lot more thrombus in the right renal side and into the IVC. And actually, an outside place was, called, this could be a renal mass, which I think not unreasonable. Like it looks like a soft tissue process, and it's extending into the renal vein and maybe into the IVC. But one clue is that this looks really bland. It doesn't look like tumor thrombus that would be enhancing, etc. So
Is this a guy or a woman?
it's a female.
Is she on OCPs?
She's not.
Oh.
But anyway, this was the follow-up MR then a little while later. And now you can see that there is even more extensive thrombus in the IVC and in both of the external iliac veins. Common iliac veins. So the entire IVC now has this bland, non-enhancing thrombus. It's also in that right renal vein. The left renal vein thrombus, there's a little bit residuum there, but most of it is resolved. So it was just an interesting case where it seemed to have started on one side, it progressed to the other side, it ended up progressing to the entire IVC and common iliac veins. IR was consulted. They came in and did a mechanical thrombectomy, put the patient on IV heparin, and they did a hypercoagulable workup, and the patient had antiphospholipid syndrome. So this is just a patient who was just hypercoagulable, who presented with the renal vein thrombus. So I guess the take-home point is not everything, and our urologists were really like questioning us, like, wait, I haven't seen this before. Like, isn't this a mass here that's causing, you just used to saying everything that does this is an RCC. And it looked kind of, really unclear, but I think the MRI really cleared it up and showed that it was a non-enhancing bland thrombus. So, okay, that's my case. That was a great presentation, Maria. Thank you so much.
Thank you.
I have one case to follow. Maria is like a pelvic mimicker.
Oh yeah. Do you want to show it now?
Yeah, sure. One second. I should was a patient who presented with like swelling of the scrotum. So he's like 47-year-old. He went to Mexico like a few years back, and then he had scrotal silicone injection and also into his phallus. So all that we are seeing here is sorry. All
This
that
is
we're seeing
awesome.
is like
This is oh my god.
I've never seen like a scrotal silicone, like not like we've seen like
This is the first
implant.
time I'm seeing one.
Me
were
too. I didn't even know people
Impressive.
did this.
Yeah, I didn't know either.
Apparently like they injected 600 cc of silicone in one and 500 on another, and he had like severe granulomatous reaction.
Oh
And
wow.
subsequently like patients like the primary care injected some steroid into it, and like none of them worked. And then like now we can see like his scrotum is like up to his mid thigh, like it's like giant sized one, and his testis is like kind of like can't even like find it. It's small, but it was normal. But all of these are like silicone granulomatosis in his
Wow.
scrotum. And he had
This
small
is-
little ones in his penis too, penile skin. So I thought I'll just show you, but it's like a continuation. So I thought I'll show.
That's an amazing case.
I know.
I can't believe what the things that people go through to enhance their appearance.
Yeah.
But anyway, okay, awesome. Great cases, guys. I will see you next time. Bye.
Thank you.
Thank
Bye
you all.
everyone. Bye.
Holidays.